Hey, everybody. Thanks for joining me today. Mark Callanen here, Director of Clinical Education from Innovus Recovery Sciences. And we have a little different flair on our webinar this month. We're fortunate enough to have a veteran in the PT space, Paul Marquis, and he's been practicing for quite a while. And he's going to talk to us a little bit about radicular problems from the neck and some novel ways that he's come up with over the year to assess this and treat it. So, Paul, thanks for joining me today.
Well, thanks for having me, Mark. I really appreciate you bringing me on.
Yeah, we've never had a conversation quite like this, so I'm looking forward to this. Maybe you can let everybody know a little bit about yourself. I know that you've been in the space since 1992, so you got a little bit more salt than I do in the space.
Yeah, I've been at it over 30 years and really totally passionate about what I do. And I'm super glad that I became a physical therapist and plan to do it for the rest of my career. And yeah, I graduated from the University of New England in 1992 and worked for County Physical Therapy. Now it's going to be just about 30 years here in another couple months, and doing primarily outpatient sports and orthopedics. And I have, I was the vice president of clinical operations at County Physical Therapy now for over 15 years, and just loved doing orthopedics, and just got excited every time we saw more orthopedic stuff. I just love to see more, do more, learn more. But as with any profession, evaluating ACLs and rotator cuffs and cervical spines, it gets pretty routine. We see a lot of it. So I decided I wanted to jump in a couple other things just to kind of fuel my my physical therapy fire. And one of them was to become the host of the Ortho Eval Pal podcast show. And I just hit episode 266, I believe, yesterday. And on top of that, I had been to a couple of courses and, got a little bored when I was at the courses and said, I can do this myself. And so decided to open a small company called Maine Orthopedic Seminars, where I do live courses and some online courses, downloadable courses on shoulder dysfunction, cervical spine, lumbar spine, knee, foot and ankle. Usually bring in some great lecturers, orthopedic surgeons, neurosurgeons to elaborate on some of the technicalities of these issues, and really love lecturing and going around the state of Maine, helping out. And I've done a few other courses in California and the Boston area, and truly enjoy doing that. I love to educate as much as possible. And then I also just had a little entrepreneurial mode in me and decided I wanted to develop the Easy Slant. And so I became the president and founder of Easy Slant LLC, where we developed a portable slant board to help stretch the calves and use it for multiple foot and ankle issues. And that's been a fun little project of mine. So I like to stay busy, as you can tell.
For sure. And I know listeners usually want to kind of get a sense of what your daily patient population look like. So as far as your day-to-day clinical look, what is your patient mix?
Yeah, so I see everything from adhesive capsulitis to Achilles tendinopathy. I do a lot of orthotics. I do a lot of footwork. One of the only physical therapists in the state who does that. And I utilize an orthotics company, and we work really well together. And actually lining up an orthotics presentation here just before we were doing this, just for this talk today. So I really enjoy doing that. But yeah, see everything from carpal tunnel to cervical spine dysfunction, to knee and shoulder dysfunction. It's pretty much all orthopedic and sport oriented.
So it sounds like there was definitely something that sparked an interest in taking a closer look in your neck patients, specifically the ones that were having radicular complaints, which is the focus of what we're going to chat about today. Maybe you can talk a little bit about what happened to get you really sort of to dive, all in on checking out this problem, maybe getting a little bit better at addressing it.
Absolutely. So I, there are some special tests out there that can help identify if somebody has a cervical spine issue, if they have radiculopathy. There's a Sperling's test, the distraction test, and the compression test of the cervical spine. And I never really used the cluster too much, but I have been a lot more lately. But I've been big into sensory testing, myotomal testing, and reflex testing. And the issue that I've always had with these special tests is that they can help kind of rule in if it's a cervical spine or not, but it didn't really give me a lot in regards to specificity of what level it was at. I was looking for something that could help really determine if it's a cervical spine problem or a shoulder problem. And I wanted to break that up. And just interestingly enough, as I was mulling this through my head with many, many patients that I have seen, and I work really closely with a neurosurgical group, and we have these discussions all the time about how we can make this better. Well, I had this patient who came to see me. She came in a sling. She had injured herself 2 weeks earlier. She had slipped and fallen on the ice. And when she did, she landed on her butt and also struck her elbow pretty hard on the ground while she was on the cell phone. Ended up in the emergency room because she was having such severe shoulder pain. And they did, a few x-rays and put her in a sling and gave her some medication. And 2 days later, she came back to the emergency room. It was excruciating pain. They did an MRI and determined that she had some tendonitis in her shoulder. And so they kind of let her go with that, with the sling, give her some more medication. She ended up in her PCP's office, and her PCP sent the patient over to us. And when she came in, she had perfect cervical spine range of motion, but she could not lift her arm like the picture that you see on the left here. Really a lot of shoulder shrugging and had no active flexion or abduction of the arm. It was incredible. It was very impressive at how weak this was. So I had to start thinking, well, was this a complete tear of her rotator cuff, or could this be something else? And I don't know what possessed me to do this, but I just decided I'm going to stand behind her. I'm going to traction her neck to see if her range of motion improves, to see if this is possibly some sort of a cervical spine issue. And so as I gave her some traction, I asked her to lift her arms, and she was able to fully flex her arms. And interestingly enough, when I let go of her neck, her arm started to collapse and it fell. And so I did that several times. And when I tractioned her, we were obviously taking some pressure off the nerve root of the C5 nerve root, and she was able to flex that arm really well. So I then started to think there's got to be a better way to help identify, is this a cervical spine problem or a shoulder problem, and try to identify the level. So if you don't mind hitting the next slide, what we then did was start to test different myotomal patterns while people were in traction. So what I would do is I would traction the neck, test their strength, and interestingly enough, the strength at a particular level would improve. And so we then thought, well, how can we throw this into a study and objectify it a little bit, because just using my hands was going to be very difficult to measure. So I'm not great with research as far as putting it together, but I thought, you know what, I can gather all this data because I see a tremendous number of patients with nerve root compression problems in the cervical spine. And I've done a lot of shoulders, and I can really tease that out really well. But I'm not great with the gathering of the information, putting the statistical analysis and all of that data together. So I connected with Hassan University, and they were gracious enough to take one of their classes, put it together, and say, okay, we're going to work on this and piece this information together. So what we did was we placed the patient on a table flat with no pillow first, and we tested different muscle groups to identify, C5, C6, C7, T1, just to see if they had any loss of sensation, loss of reflex, loss of strength. Then, so we assessed all of that. We used a dynamometer to gather their information in regards to their strength, which was what I focused on the most, because when somebody has weakness with a nerve root compression problem, that seems to be the bigger red flag where we have to kind of expedite, where they go and what they do. So then what we did was,
how do you find the reliability on those hand dynamometers have been in the clinic? I know it can be a lot easier if you have a weaker patient, but I mean, sometimes you get a bigger, stronger person, and then you got to sort of fight with them. Have you found that using it just in your hands, or I've heard some clinicians, try to affix it to something that's more stable? What's been your take on that?
So in this particular position with these patients, I can overpower that really well. So as you can see, I'm really locking myself in, and I'm using both hands, and I'm holding really tight. And that worked out really well for this particular study until we got into the hand and the fingers and things like that. It became a lot harder. But if I were doing this on a leg, I would definitely affix it to something solid, just because people could just overpower me. But in this position, it was pretty easy. The other thing that made it easier is that all of the subjects had quite a bit of pain and weakness. So they were definitely not pushing as hard as they did on the good side. But at the time I was a little younger, a little stronger, and really was able to hold it nice and steady. But I find the dynamometer to be a great way to objectify a lot of these issues and, show patients improvement or lack of improvement, and then I can show the doctors that, and then they can take that information and do with it what they want. But I find they work fairly well.
And then obviously in this picture, the other piece of technology you're utilizing is the Saunders traction. So, to do manual distraction while you're checking strength, and obviously you only have one set of hands. Maybe you talk about how that fit and why you thought that would be a good way to do this too.
Yeah, so the issue that I kind of was thinking about is if we do this study and we have two people, one person tractioning the neck and the other person doing the testing, it requires two people in the office if you see that patient. And then you can't really measure how much traction you're giving there. So I didn't even think twice and started to use a Saunders Cervical Traction Unit because it was a device I had been using for several years before the study because I like it so much. And I'll talk about kind of the features of why I like it. But we were able to, measure the amount of traction. We could put them in 15 degrees of cervical spine flexion. And I also brought them into 15 degrees of lateral flexion to the opposite side. So here with this young lady, I have her shifted to the right side, 15 degrees. So we always did that.
Did you use an inclinometer or anything to get the 15 degrees of tilt?
Yeah, I used a goniometer from above the patient, and we were able to measure it that way, just for the consistency of it. And then what we did is we brought them up to 18 to 20 pounds of traction. And then I retested the sensation, the reflexes, and the strength. And interestingly enough, if we did 4 different levels, the area that had the most nerve root compression would show the most significant increase in strength while they were in the traction.
So when you say levels, you were trying to isolate the vertebral segment that we thought was involved. Did you just do that through palpation or changing the degrees of lateral flexion?
Nope. So what we did was we tested the biceps for C5. We did wrist extension for C6, triceps for C7. And we tested those different muscle groups. We kept them in the same position while they were in traction and just retested all of them. And interestingly enough, when they were in traction, we saw an improvement in strength. And then when they were out of traction, they would lose that strength again. And so the area that showed the most improvement in strength was consistent with the most specific level that was, being impinged upon. And so interestingly enough, whenever I utilize this test, not only can I tell what level it's at, but it has been, with me personally, a really good predictor at how people do after cervical spine surgery. So if they have a decompression surgery or cervical spine fusion, if they show a pretty significant improvement in strength while they are in traction, it's a pretty good bet that once they have that nerve decompressed surgically, they're going to have better strength afterwards. But if somebody comes in with pretty significant radiculopathy and they have loss of sensation, loss of strength, and loss of reflex, but they don't gain strength with the test, I can kind of predict that they will have some difficulty afterwards, and it could take a long time to regain that strength after they've had surgery.
Do you think that's because of the chronicity of the impingement on the nerve, so there's true damage there, or do you think that's just due to it could be a multi-level problem, or what's your thought on that?
Most oftentimes it's the chronicity and it's the amount of nerve root compression. So if it's a large herniated disc that has damaged the outer layer of the nerve root, they are more likely to take a long time to regain their strength. And actually the young lady that had done the study around originally, she regained about 80% of her strength, but she had gone 2 to 3 weeks because it had been unrecognized early on. So that when they did surgery, they noticed a significant amount of nerve root compression and damage to the nerve root. I saw her 15 years later, and she still had some weakness, but a significantly more functional arm than what she had before.
Has it gotten to the point with your referral base from your neurology base that when you do this test and you provide that feedback, they've stated it has any impact on, what they're doing, or are they just sticking with what they're doing with their own process and MRIs and such?
So the neurosurgical group that I work with have recognized that I can really pick the level and the significant amount of compression quite well. And so what we did was, with these people, we did not look at their MRI findings until after the study was done. And we were able to predict which level it was at. And so when I speak to a lot of neurosurgeons, I can really tease out which level it is, and talk about, how severe it is in regards to, their gain of strength or loss of strength during traction. So now it's one of those things where, after having put this information together, we really could have done the study with many more subjects. And I really wish somebody out there would say, hey, we'd like to make this bigger and better. And I definitely, work with somebody with that, because I think there is a lot to be said about not only picking the level, but also in regards to, identifying if they're going to be a good candidate for surgery. And it also helps to get rid of the shoulder. It takes the shoulder out of the picture. And that I find has been very helpful, because some people, it's very difficult to identify if it's a shoulder or a cervical spine nerve root compression.
So how accurate were you when you went back and compared it to the MRI findings? What was
extremely accurate. One of the students who was in this study also continues to use this in her own practice, and states she uses it probably on a weekly basis. I use it constantly. We've educated all of our staff here. The university dubbed it the Marquee maneuver, just so that they could associate this particular test with the study that we were doing and the information we were gathering. Just made it easier for everybody to recognize that this is what it was. And I use it a lot with really good accuracy.
Is 18 to 20 pounds sort of the standard for the amount of distraction?
It's really the standard. I think if I were to do the study again, I would go more than that. I find that when I do it manually, I can get just a little bit more. And it seems to give us better information when we're doing the strength testing.
So you have a student that's been utilizing this in the clinic quite a bit?
Yeah, so we, at the time, one of the students that was in the research project, continue to use this as an evaluative tool for her, and she still uses it to this day. I use it on a regular basis, maybe a couple times a week. Anytime I see somebody with some questionable nerve root compression at the cervical spine, I bring in if I've got a therapist who can be there with me quickly, I'll do a cervical spine traction while they are testing the strength. We'll do the strength test before the traction, during the traction, and after. And we can pick up that level pretty well. And it's been really fun, because if somebody's questioning, is it shoulder or neck, this is simple. We do traction, and if the wrist extensors get stronger, it's obviously not a shoulder problem. If their pain level gets better, that's also from the traction and decreasing nerve root compression. So I've really used it for both of those.
Yeah, and what's nice is often in the clinic we do tests and measures and try to get a sense of something that's involved, but it doesn't necessarily lead to a treatment solution. The nice thing about this test is it does kind of point you towards, hey, you probably want to bias your traction towards some distraction, or your treatment towards some distraction, as far as how to approach the problem. So I think it's a nice streamlining test on that front.
Yeah, exactly. And then when we hit that point where we were pretty sure that the patient has some nerve root compression, we might push that down the line, and that might be a call to the PCP, get an MRI, get the patient over to a neurosurgeon, maybe have an EMG. Well, there's going to be a time block here where they're going to be in compression of that nerve root, in that foramen. And so what I'll do is I will traction them manually first, which is something I always do before I put them into mechanical traction, and see how they do. And if they do well with that, then I place them into mechanical traction, see if we can reproduce that sense of relief, improved strength, and less paresthesia, less pain down the arm, scapula, or chest. And if they do well with that, then what we do is we encourage them to get set up with a cervical traction unit at home 3 times a day, 3 to 4 times a day. I like to do about a 3-minute pull at 15 pounds, and then I bring them up to about 18 to 20 pounds for 15 minutes. I always have them use a timer so they don't fall asleep in it. I love the Saunders Cervical Traction Unit because, number one, it's portable. You can adjust the occipital pieces so that you can make that comfortable. And they can set it up themselves. They can add the pressure as they need. They don't need a second person to set this up. And I also like that you can increase the back side of it to bring them into flexion, 15, 20, 30 degrees at different angles. Some people really require a lot of flexion during traction to get some relief. And that's one of the things I really like about the Saunders cervical traction is that it's so versatile that way.
And what's the mechanism you use to get the device in patients' hands? Like, how do they acquire it?
Yeah, so I usually utilize MedCore professionals. They are a group in Maine here. I basically fill out a form, fax that to them, and they take over from there. They contact the patient. They make sure that they have authorization through the insurance. If the patient owes something, then they contact the patient and say, this is what the amount is going to be. Do you want to continue moving forward with this? If the patient agrees and there's good coverage, they get one sent right up here right away. And it's really a pretty quick process.
Got it. So we kind of got ahead of ourselves, backing into the study you put together. These are the notes from your poster presentation. Can you talk a little bit about sort of how many subjects you had and where you presented this?
Yeah, so we just did one case study on this one, but I had when we did the study, we had 8 subjects. I did all of them here in our office. I made sure that we had a table that was relatively firm. And we utilized the Lafayette dynamometer for the manual muscle testing and the Saunders cervical traction, so we can get some objective measurements and keep that that angle consistent with everybody. And so I gathered all the information in our study here. Husson University gathered the same information on a control group and compared the two.
So it looks like this mostly tracked the results that took place, pre-test. You checked strength, and then you were doing the traction during, and you checked the strength, and then you brought it down and you checked it again. It looks like it pretty much returned very close to sort of that baseline. What have you seen clinically, when you do this as sort of a treatment in the clinic and they don't go home with a traction device versus when you do this in the clinic and then you are able to get them hooked up with a Saunders unit? What do you see as a pathway with these patients in both cases?
That's a great question. What I find is that, if you're doing traction 3 times a week for up to 20 minutes each time, it's great. You get some relief at the time. The patient may have less paresthesia. They're obviously getting less nerve root compression. It gives them a chance to relax a little bit, but the carryover is variable. Some people get it just while they're in the traction. Some people, it's a couple of hours. I've had people go a full day of relief. What I have found to be much more beneficial is when they do it 3 or 4 times a day. If they can get it in, work it into their schedule, I really encourage 3 to 4 times a day. They just have a little bit more carryover between sessions. And I've had people who were kind of lined up for surgery kind of resolve. I mean, we know that herniated discs can resolve themselves, and physiologically, your body recognizes the herniated disc as a foreign substance in that area. So it eats it up, it gets rid of it. And in good time, people can do really well, even with large herniated discs. The problem is that if they have too much nerve root compression for too long, that's when they run the risk of permanent nerve damage. And so if we can minimize that amount of nerve root compression, in my opinion, that really just, kind of buys them some time, either throughout the healing process or between the time of their injury and the time of surgery.
So does their presentation on the acuity level, if say they're 7 out of 10, a real acute problem versus maybe subacute 5 out of 10, or more chronic low level 3 out of 10, let's say, or less, does that impact how much pull you recommend and how many times a day they should be applying it?
I try to get them to a comfortable level. So if I traction them straight and they're not getting any relief, I may push them into more flexion to get a little more relief. If that works, great. If they're not getting that, then I will tilt them to the opposite side of the radiculopathy just to open that frame in a little bit more. And so I make those modifications per patient. And it's just amazing at how they all respond a little bit different to different angles. And if some people have some nerve gliding issues, they may not like to be tilted to the opposite side. They like to stay nice and neutral. So I make those modifications with them while they're in the traction in the first couple of minutes. But I think most importantly, educating them about the safety of the Saunders Cervical Traction Unit, explaining to them what it does, and I show it to them on a spine model. And I think once they understand that, then they feel much more relaxed while they're in it, because if they're uptight, they're going to fight it and just kind of tighten against it. So if I can get them to relax a little bit better before they do it, I have much better results.
So there are people at home you're sending home with to do this in some slight lateral flexion with the pull.
Yes.
Yeah.
And it's really easy to set up, actually. Once they are in the device, all they have to do before they pump themselves up is take their hand and tilt the device to the opposite side really lightly. And I usually tell them, 5 to 10, 15 degrees max. I do it in the clinic here so they understand how to do it. And I also have them set themselves up in the clinic before sending them home. If we don't have that opportunity to teach them how to do it, I have a YouTube channel, and I send them to the link on my YouTube, and I explain to them how to set themselves up. And so they're able to get there, watch that, and then feel much more comfortable taking care of themselves.
So just for clarity, for your ideal home program with this unit, how often do you like your patients utilizing it, and how long do you see, or how long does it take before you start seeing things calming down when you set prognosis for your patients?
Yeah, so it's usually a couple of days before we see some improvement that lasts a little bit longer. They typically have improvement while they're in the traction, because we are mechanically opening up that foramen, taking some pressure off that nerve root. And so mechanically, they get some relief right away. It's the carryover that seems to get better as they do it a little bit longer and do it more frequently. So like I said, I like to go 3 minutes of 15 pounds just to get them comfortable in it, get them into the right position. Then I bring them up to 18 to 20 pounds for 15 minutes, 3 to 4 times a day.
So I think that's an important point for everybody, because, whether you're treating with some other device for a problem or you're using this unit for a radicular complaint, patients are going to really sort of want immediate results in most cases. And depending on the tissue you're dealing with, sometimes it doesn't heal, in an hour or in a day. And setting that expectation for the patient is very important, so they don't get disenchanted or think that your plan isn't appropriate or working. So by telling somebody, hey, this is going to help, but it might take a week before you really start to notice significant change, or it might take a few days, that can be the difference between a winner and a loss. Would you agree with that?
Right, exactly. And the other thing that I do with patients who if they purchase the unit is, and I've had several people tell me this, that, I use the unit regularly for a week to 2 weeks, and then I started feeling better, and then I started to use it just, once a day. Then I went down to 2 or 3 times a week. And then, I might have gone a couple of months, and I was painting a ceiling, and I started to have some pain go down my arm or into my shoulder blade. And then I just jumped into it at night just to give myself a little bit of relief. And they seem to do really well with that and use it kind of like PRN. And they might use it in a month, they might use it in a year. But I've seen some people utilize it just to give themselves a little bit of relief. Some people find it, relaxing to use it in general. You need to think that gravity's pushing down on your head all day long, and your head weighs 10 to 14 pounds. Your facets are being compressed. Your discs are being compressed all day. We're fighting gravity all the time. So it's a healthy thing to do, to stretch that neck out, even if you're not having symptoms. I find it, very comfortable and very relaxing. One of the other things that I emphasize if people are using the Saunders cervical traction is to put a roll under the knees, just to get that pelvis rolled back a little bit, and that relaxes the rest of the spine. Turn off the lights, put some quiet music on, and just relax into it. And
so on that sort of long-term management front, the research supports traction for the nerve radicular complaint. Not so great what's in black and white for treating with myofascial pain. But what have you seen just empirically with patients that are maybe using it as a self-management tool? Do you think for those people that have tension, that have some soft tissue issues when they get themselves in that relaxed state you're talking about and use this distraction, do you find it makes improvement with their complaints or what they give you as feedback, or is that not move the needle very well?
Yeah, I have the best results with those who have nerve root compression by herniated disc. I have good results with those who have facet inflammation and facet compression. And then the third in the bunch would be those who have just myofascial tension in their necks, and they do get relief with that. I'm a very big believer that myofascial upper trap and cervical muscle pain comes from an underlying issue, usually facet or disc oriented.
Yeah, I think that's just an important note for especially maybe some of the younger viewers out there that are newer to the profession and they're trying to get their special tests in line. And they're trying to be as evidence-based as possible. Often the research that we're utilizing to try to make these predictions and these rules are okay. maybe they're good, but very rarely are they great. So often there's things that can slip between the cracks on how to use some of these tools to your benefit. And even though it's not maybe jumping off the page from a research front, seeing it and trying it on a couple of different patients just to get a sense of maybe it can help with a facet, maybe it can help with some myofascial. And certainly if it doesn't, okay, moving on after a few patients and go, okay, it doesn't seem to help that type of patient. But I would challenge everybody out there to whatever techniques you're doing, whatever you're trying, apply it to different types of patients, apply it in different levels of acuity, see what your result is. And you might surprise yourself finding some of the things that work and don't work, right?
Yeah, and I've been at this for a long time, and I've always had issues with, do we follow the evidence or do we follow experience? And I've seen in other orthopedic issues, many orthopedic issues where, if you were to follow just the evidence alone, patients could end up going down the wrong path sometimes. And I've seen hundreds and hundreds of these types of patients with cervical nerve root compression. And I know what works, I know what doesn't work. And I know how to manage these really well. And when I call the neurosurgical group that I work with, they're like, yep, let's set up a telemedicine. Let's get this person going right away. And there's no question about it because of, the way we evaluate those patients and the way we manage them. And they feel that if we have seen them and we have done therapy on them and they are not getting better, then they are definitely more likely to be a surgical candidate. And so experience really helps a lot in these situations.
So for our evidence-based fans out there, I'm sure you're familiar with the power of clustering of tests, and cervical radicular patients certainly fit into this. And this is just something I came across, which I think is pretty common as far as a 4-test cluster for cervical radiculopathy to rule that in. And by combining, Sperling's test, upper limb tension, a median nerve glide, essentially cranial distraction, which is similar to what we've been talking about today, and then the involved cervical rotation test, which is basically putting the neck into flexion to take out mobility in the lower cervical spine and then rotating towards the involved side. If it's greater than 60 degree or less than 60 degrees of rotation, it's positive. Putting those together, you basically increase the likelihood that there's a nerve impingement of a score of 30.3, which is quite high. So with that being said, the average evidence-based tester would say, hey, we're in pretty good shape if we use these. What would you say with what does your test offer, to add to this or improve on this? Because I think some people would say, hey, a 98% specificity on the cervical traction test, that's pretty good.
Yeah, I mean, it falls right into what we've been doing, and it justifies, the results that we're getting as far as my ability to take a patient who has, right arm pain and identify if this is a nerve root compression problem or not. And so, yeah, it falls right into place with that. And I love it because of that. And that's why I continue to do it with really good success and predictability. So, yeah, it's really meets what we were doing with our study. And I really didn't do a lot of cluster testing. I'm old school. So we never understood it as a cluster 30 years ago when we studied it. We knew that if somebody had a loss of sensation, loss of strength, loss of reflex, positive Sperling's, upper limb tension, cranial distraction, all these things. And if they had this, well, it kind of fell into what we knew was a nerve root compression. Just never understood it as cluster before until recently. And but yeah, when you look at the specificity of it, it really helps verify what we've been doing.
Well, I think what your test adds to this is that by doing the myotomal work while they're under traction and distraction, you get a sense of which nerve root is involved. So it kind of brings the story a little bit more focused as far as which level is probably the primary one involved. So if you're choosing to do a manual distraction and you were trying to pick a segment in the spine, or to your point earlier, if you're talking to a surgeon and say, hey, what do you think is the primary problem? Hey, clinically, it's looking like C5 is really jumping out for this reason. That's all good information. You might not get that level from just doing this cluster.
Right. And then it just helps to fine tune your evaluation a little bit more, because there are so many lookalikes out there. Like a C5 nerve root compression looks just like a rotator cuff tear. If somebody cannot lift their shoulder, it looks like, and I've got tons of pictures of people with cervical spine C5 nerve root compressions and rotator cuff tears. And some people who just have rotator cuff inflammation and they can't lift their arms, they all look alike. And so we think a little more specifically when we are doing the Marquee maneuver or doing this test, because we can really hit those levels, and it makes us think a little bit more, and it really fine tunes it. So when you kind of predict it and then they go have that MRI, and I tell the patient, I'm pretty sure you have a C5 nerve root compression. They have that MRI and they come back and they say, yep, you hit the nail on the head. Then that really builds value, and it builds confidence, and that patient is really much more apt to listen to you and do what you tell them in regards to management and treatment later.
So how do you utilize it for the person that's maybe less impinged? Maybe they have something very early stage minor. It's more on the subjective side where they're having some, referral into the upper trap shoulder area, maybe, and those are obviously the challenging ones because that can be a handful of different things. Have you found that your test is beneficial to tease out and differentiate it from a facet problem or from a general myofascial problem, given that probably the strength isn't going to be impacted by that person who's just in a real early phase of a nerve problem?
Yeah, absolutely. I think it gets a little difficult if they're not fully involved. If they don't have a large herniated disc, it makes it a little harder. So using a dynamometer can be helpful, assessing the strength before, during, and after the traction. So yeah, and again, when you traction, it changes their symptoms. I think a lot of people think about radiculopathy as pain going down the arm and forget that nerve root compression in the cervical spine can cause chest pain, and it can cause scapular pain. And I don't know how many patients I've seen who have been treated for rhomboid dysfunction when they have had a C7 nerve root compression all this time. And so I think we need to remember that the presentation of radiculopathy is not just in the arm. And so if you can change somebody's chest pain by tractioning their neck, that can tell you a lot. That can prevent them from ending up in the emergency department because they're having a left chest pain. If you traction them and do a Sperling's test and you find those to be positive, you can really redirect them.
However, if somebody's saying they have left chest pain, you probably want to be safer than sorry. And
yeah, they usually end up there. Yeah.
Yeah, right. The thing that comes to mind, I can already see some of those people that are wiggling their nose or their hands because they're thinking about 5 or 6 other specific tests that have great specificity or differentiating abilities for myofascial and facet. I'm by no way suggesting that this test replaces all those things. It's just that this may be able to tell you some of that information as well. And then obviously you would progress into those more specific tests to rule in the facet, do closing maneuvers, things of that nature to really help you answer that question. So don't think I'm trying to state that this Marquee test is able to replace everything. I'm not saying that at all. And if it has a place or fits in a piece for that type of patient that comes in with a certain presentation and it helps you figure that out within 3 or 4 minutes of doing your assessment, that's wonderful. But obviously you need to continue to do your full screen and put the whole picture together too. Absolutely.
It's a tool, and just like we spoke about earlier, it was just really interesting that I had done a YouTube video on the cervical radiculopathy cluster. But I made it very clear once I was done demonstrating how to go through that cluster that you should still complement it with reflex testing, manual muscle testing, and dermatomal testing. Because you really, to make sure, you just throw some of those extra tests in there, and it's a tool just like any other test out there.
So if folks want to get a hold of you, Paul, this is the best way for them to do it.
Yeah, absolutely. I'm at paul@orthoevalpal.com. I have a website called Ortho and you can get me through there. This email is probably the best way. I'm also on Instagram, and I have, near 500 videos on YouTube, and folks often will send me comments or questions through that source also.
Great. And for everybody that's watching, if you're interested in getting a hold of a Saunders unit or want to know which distributor you can contact to get a hold of it, please reach out to us at this telephone number or website. You can go to our Light Force Medical site. Currently, it's still a big part of our ability for you to connect with us. As of 2023, we'll probably have this all connected up a little bit better with our Chattanooga website, but right now we have two functioning sites. So if you're interested in getting any pricing or anything, you can do that. And then if you want to follow us on social media, you can do that so that you can be aware and alert of when we do our future webinars and all the good stuff that we try to put out to help educate and get everybody on the same page with how Chattanooga and Light Force devices can help you out. So, Paul, really great discussion today. I appreciate you sharing this special test that you've helped refine. And hopefully it's going to help some of the people listening have a little bit more comfort when they're dealing with that type of patient on not only how to diagnose the problem, but also how to point them in the right direction as far as treatment.
Yeah, thank you so much for having me on the show, Mark. I really appreciate the opportunity.
Great. We'll have to have you back and we'll chat about something else. It'll be fun. So
yeah, that'd be awesome.
Figure that out next year. But thanks, everybody. Appreciate you joining us today, and we'll talk to you again soon.